So hi everyone, I'm Dr. Arturo Loaiza Bonilla, GI medical oncologist at Cancer Interventions of America. Today we are going to have a very good discussion about cancer care in the time of COVID-19, which is, as you know, is a very unprecedented, interesting time, not only for us as providers, but to many of our cancer patients. And we want to have this opportunity to bring a very esteemed panel of actually folks that I had the opportunity and the luxury to work before. The idea is to have a very lively discussion and collaboration. We have Dr. Christina Gomez and we have Dr. Helosia Soares as well. And we're gonna have just a couple of questions that patients and others have really brought to us and see how can we adapt to these times and things that we can do to improve not only the quality of life of our patients, but also ourselves as providers taking care of those patients in the front line. So once again, we have Dr. Christina Gomez from Yale University, Dr. Helosia Soares from the University of Utah, and myself included. You see my faces there. So the first thing we wanted to start is with a few questions, and that's the idea of this format. So I'm going to start with, how are you managing your patients with gastrointestinal cancers during COVID-19? So I think Dr. Gomez, Christina.
Thank you. So thank you, Arturo. Thank you, first of all, for the invitation, the opportunity to be here with my colleagues in the same line of work across our country. And one thing that this has shown us is not only across states, but across the globe, we're coming together. And so how are we really treating cancer patients in this era of a very infectious, very contagious disease that is not only affecting our lives intimately, grocery stores, getting gas today, I didn't know what to touch, but what about our cancer patients who by definition are already faced with immune compromise or low white counts or challenges in and of itself by the disease as well as from their treatments. So Yale right now has done an extremely heroic, I think, concerted effort. It's been amazing. Our support, our communication has been overwhelmingly strong. The team is solid, and our particular GI DART team has been able to convert things mostly to telemedicine. Some of our patients in the elderly population are having a hard time with establishing my chart on a smart device, so we're doing a lot of phone consultations. We're only seeing active treatment patients in the office right now. And as of this week, there's more PPE usage. So now everyone from the front desk to physicians to nursing, everyone is using at least a mask in contact with any patients for their visits, to see them, and of course, then to do their treatments. Everyone's having their their temperature taken. Unfortunately, they're coming in alone. No relatives are allowed in. And lastly, as a GI oncologist in particular, we're trying to adjust chemotherapy regimens. So things like infusion of 5-FU that we were doing over 48 hours, we're wondering, and we've sat together and we're trying to transition patients to oral chemotherapy. This allows for two things. Number one, patients can take their chemo home, so oral capecitabine instead of the infusion of 5-FU. And two, it delays the time or extends the time to coming to the office. So instead of every 2 weeks, now an every 3-week visit allows for a longer time away from visiting us, perhaps, and therefore less exposures. So these are the early things that we're doing today. And I find that this can change tomorrow, but this is what we're doing today. I'm trying to convert all of these infusional therapies to oral agents and seeing patients that are only on active treatment.
Right, it seems like a all hands on deck approach at all these large cancer centers, and I think it reflects I think what we had been discussing earlier as we prepare in this webinar, that we're trying to do the same procedures. So I appreciate your input from what you're doing at Yale. So now Dr. Suarez, we'd love to get your input as well.
Yeah, thank you, Arturo, so much for the invitation. Thank you, Total Health, for the opportunity as well to discuss this, which is really important because it's affecting all of us, as Dr. Gomez Christina also mentioned as well. So here we also took a very early approach and very aggressive approach in trying to minimize in-person visits. So we are essentially converting whenever it's possible the in-person visits to video conference or telephone. Actually, I'm blessed that I have a nurse that is even calling the patients the day before and make sure that they're very comfortable with the video conference process. And she's even practicing with some of my patients, particularly if they're a little bit not as techno savvy. So that has been super helpful to keep the flow during the consultation visits. Is also one thing that I think is very nice of converting to video conferences, that you don't lose the opportunity to even show the scans to your patient, because there are ways that we can share the screens. So to some extent, it has been also, I feel, a very good experience. The other thing that we are doing is patients that are having visits just for surveillance and to review scans during surveillance, we're actually, when possible, delaying that to when is more appropriate. Patients that have stable disease in their metastatics and they have stable disease for some time, we're actually discussing even giving a break from chemotherapy to follow some of the guidelines for big organizations as well. And as has been mentioned, whenever we can convert to a regimen, then we allow patients to come less. We're doing so. For example, as mentioned, converting full Fox to Zelox, or just 5-FU infusion or to capecitabine, things like that. But we're very grateful that the leadership here, both from the Huntsman Cancer Center, our Cancer Institute, and the University of Utah, have been really kept a very open and intense communication with us to allow for us to continue to care for patients in a safe and proper manner.
Right, and thanks for the input as well. I think it makes absolute sense that we're really making that fully by example, the social distancing rules, by having those patients not coming to our facilities as often, and discussing those chemo breaks that sometimes actually patients look for, and actually this even gives more validation to those opportunities for those patients. And if you don't need to get a CAT scan right away, I mean, a couple of weeks may wait. That wouldn't be a problem. And sometimes we're actually doing it as well as locally. So I think, kind of a paraphrase, I think we're all trying to do the same thing, following major guidelines, following examples of other centers outside of the US that started with this pandemic and dealt with it, following examples of China, Italy, and others. So also we're using telemedicine at Cancer Treatment of America now that all these limitations have been lifted. So in the past, we had a lot of restrictions on the use of telemedicine on telehealth initiatives across Medicare and commercial payers. But now with the national emergency, we actually have a chance to offer those services to patients, even using a cell phone. All the HIPAA privacy restrictions have been lifted in terms of using these apps that before there had to be HIPAA compliant. Now we can call patients and have the discussions and still being able to serve them as if they were coming to our facilities. We'll also change patients to oral drugs when appropriate, and discussing those schedule changes that both Dr. Gomez and Dr. Suarez had mentioned. In terms of diagnostics, we're using liquid biopsies and home phlebotomies frequently now. So for example, if a patient needs some genomic testing to be done locally, we can use those phlebotomy services for those patients to go in. And also in the case of patients with who are recovering from surgery and we're discussing maybe adjuvant treatment, there's certain things that we can do now with liquid biopsies as well. So that's some initiatives that we're trying to take advantage of the home phlebotomist, so the patient doesn't have to come to our hospitals. And I think this is something that we're probably going to discuss later in this conversation in a more in-depth fashion, but just the collaboration that has happened between providers. So just these webinars is an example of that. We have like 3 GI med-oncs that we meet very often at meetings, but you know, ASCO now has been virtual, and we have to figure out what's going to happen with the ASCO highlights that we'll participate on too. But at least we have an opportunity for collaboration now with local providers, with other medical oncologists, and really exchange practices for the benefit of patients. So that's my input on this too. All right, so let's follow to the next question. What are your greatest concerns in standard care delivery outside PPE? So for those who are not familiar with PPE, we call that the personal protective equipment, which is all these things that we use like face masks and gloves and all the garments to make sure that we're protected from ourselves catching an infection, or if we are asymptomatic carriers, we don't give it to our patients as well. But we want to focus beyond PPE. We know that's a major focus of conversation now, and we probably dedicate a full hour just talking about it, but moving to other topics on that area, we wanted to get the input as well of the panel. So Dr. Gomez?
So I think our greatest concern, my greatest concern is, in particular at work, is once again what I mentioned. Our patients, by definition, with their diagnosis of cancer, and then subsequent to the treatments that we offer to them, their immune system is compromised at the get-go. So my concern is that we have an insidious, contagious threat to patients whose immune system is already in jeopardy or on high alert or already on overdrive, if you will. That being said, I'm worried about immunotherapies. Immunotherapies, and what are we doing to the immune system, or how is that going to change the face of the attack, the own immune system's attack to this novel coronavirus. So with respect to my patients and the treatments and the availability of care, in addition to that, it's just their immune system. I'm starting to be very concerned about physician fatigue. I'm home this week, but I've been in touch with my colleagues. Just this morning, I was calling her on her way to work saying, what's happening? How are you guys? They are a 2-physician household. So I wanted to know how she and her husband were doing and how they're doing with their kids, because this is what we're reading, right? So physician fatigue, what's the anxiety level? Yale as a whole is addressing that. Our humanities department, our Department of Psychology is meeting with us with respect to physician wellness and mindfulness, and that this is not only social distancing, but more physical distancing. And how do we maintain our social ties and our social supports, both professionally and personally, so as to supersede or cover for each other or stagger our levels of fatigue and anxiety, and allow for our health care to be optimal, so that then we can provide optimal care to our patients. And then lastly, I'm worried about resources all around. That's what the news is telling us now, right? We're hearing the numbers rising, the numbers in cases, the numbers in recoveries, thank God, and in the numbers of vents and things required. But my worry is also, what are our resources locally? What are we doing here? And every day, as mentioned, our university gives us an update, our local hospital gives us an update, what is needed, what's not only in staff, as well as equipment, how many beds, ventilators, etc. So my biggest concerns are all of that, like the intricacies of allowing us to provide the care that is optimal, ideal, and excellent in the time of stressed physicians, stressed healthcare system, stressed global system.
Right. Seems like COVID-19 is affecting everyone in every single institution. So we're talking now patients, we're talking providers, caregivers, and also the health system itself is suffering from this. We're trying to overcome that to some degree, but it's always a concern. I think all of us are in the same boat on that concern. Now, Dr. Suarez, I think you had a specific one.
Yeah, no, I think what Dr. Gomez highlighted is, spot on. These are concerns that we really all have. But I mean, every time that I walk into a room or I ask a patient to come, and even, could be a lab work or imaging or something that I feel that's necessary, that I always feel like it might really expose my patients to potentially getting the virus, right? I mean, because they have to park, they have to walk in, they have to press the elevator button, all these things, in addition to like could I be a carrier of the virus? So it really, that's what haunts me, is that responsibility that I really should minimize as much as I can the exposure. And that really takes into your medical decision process, like, can I really wait a little bit longer for this lab work that I otherwise will have gotten in a patient? So that's what is being really in my mind most of the time. And obviously all the other concerns that we as an institution have as physicians, as healthcare providers, in terms of having the adequate resources and equipment. But Dr. Gomez highlighted that beautifully.
Excellent. I think this is a very important points too. So on my perspective, I think it's all reflective of all that we have been talking about. So patients getting COVID while traveling or by asymptomatic carriers, which could be ourselves, or they go, as Dr. Gomez was mentioning, going to the gas station, and then what if they touch a surface that has not been cleaned? You know, the turnaround time of cleaning surfaces is always so challenging these days. So I think the best thing we can do is just take care of ourselves and be assuming that everything is contaminated this time, and just be protected of our own environment. All the things I'm mostly concerned too about standard of care, treatment, delivery is the disruptions that happen when travel. So we don't have a nationwide stay-at-home order yet, but that's something that may be anticipated. Let's see what happens. But we know that many states already have those specific restrictions in place, and there may be limitation across multiple places to travel. You know, airlines are also going to be limited, and even roads may be also constraining in movement, because they may prioritize it for you know, ambulances or for healthcare delivery or supplies. So that may also be a significant issue. And also because if our departments or our emergency departments get full, and we want to have those cancer patients be taken care of there as well, it's going to be difficult, because we first of all know there's a lot of COVID-19 patients in those facilities and that on those areas of the facility. So we need to protect them from getting any potential infection, and also if they have COVID-19, how we handle those patients after. So we know we're going to overcome this. I mean, that's just part of nature. We're going to be able to overcome this as a society, as all of us come together. We're going to find good treatments. We're going to find vaccines. But until then, how do we care for those cancer patients that have actually survived from COVID-19? So do we have designated areas for those patients? Do we have a certainty that they're not going to carry it around to other patients? Because, you know, there may be some still virus in their respiratory tracts that may be contagious. Are they fully immune to treatment? If we give them treatment, is it going to interact with anything, either immune suppressant treatment such as chemo or immunostimulants such as immunotherapy? So it's a lot of questions that are right now concerning, and I hope that we can come all together with registries and with data so we can make those informed decisions appropriately. So, all right. Next question. Since these challenges are not one size fits all, what are you personally doing differently? So Dr. Gomez.
Yeah, so so this is not the personal answer, I guess, but I myself have been at home for a personal reason. I think we're going to get to that in another slide, but I have a new baby at home, and it's wonderful. And the baby arrived as we were learning telemedicine, as we were being asked to decant our clinics. So I have been able to be at home with him, and it's wonderful. And I've been able, namely, to call my patients, to inform them about what's happening at the university, to inform them of what's happening at our center, and then to really make those decisions from home. What's right for you? What's right for you at this time? Can we delay your cycle? Can we change your cycle to oral chemotherapy? Can we delay your scans? Should we wait? Should we wait a week or two and see what happens? My concern with that has been that every 2 weeks, things have to be changed and seem to be getting a little worse. So I'm worried that the patients I've asked to wait 2 weeks or 4 weeks may be requiring a greater attack at that time, or a real greater shift in a month. But personally, what I've been able to do, this was the goal. We were decanting our clinics, only seeing patients with active treatment. We're doing telemedicine. I, however, from home have been doing mostly phone calls in preparation for when I return next week to plan their treatments. And I find that it's been very reassuring for them to be, again, active members of their treatment care. What to do, what's the right time, what do they feel comfortable with, what's their safety and their safety of their families. As a group, my colleagues, we're not going to the hospital as much right now. If we can, we service a local hospital as well, and we're doing e-consults, namely reviewing the medical record online, talking to the hospitalist team. My colleague that I spoke to this morning said that she walked into the ICU and they told her, "What are you doing? We can give you the physical exam and everything by phone." So as you guys mentioned, it is really a multidisciplinary approach. It's really a concerted effort. And I think that the connections remain, both patients and staff. We're able to provide the care that an oncology patient needs, because everyone's committed to providing this, to covering for each other, to holding hands virtually to the care of these patients.
Wonderful. Dr. Suarez?
Yeah, so personally, when I come to clinic, I'm wearing scrubs because it's easier to just, leave it at work, put in a little plastic bag, and then walk out with my regular clothes and avoid contamination. I'm not wearing any more jewelry anymore because there can also be something that we might not necessarily remember to wash in my bracelet. I stop going to the grocery store, and I just getting things delivered to my house. I mean, we all wash our hands a lot, but certainly took washing hands to an extra level of frequency, and wearing masks. Now we were asked to wear a mask during the day, all the healthcare providers here. And at work, even though we have several clinical trials, if it's a clinical trial such as a phase 3 that you can offer standard of care, I'm certainly thinking about offering the standard of care on its own without offering necessarily a clinical trial. Why? Because clinical trials might require a few more visits than you would if you're just seeing the patient on a regular basis. Unless, obviously, we have a trial that is perhaps biomarker driven, or a patient that has no other option. In that case, I will still potentially discuss a clinical trial and talk to the sponsor of the trial to see how we can minimize exposure and visits.
No, I think that's a very fun approach. I think we're doing all the same as well, trying to see what trials make sense for most patients, but also we want to keep research going, but at the same time, we want to keep patients safe. So kind of managing that balance is key.
Absolutely.
A few things I'm doing, exercising. I mean, as I think we call it social distancing because that became the term du jour, but I think I agree it's more like physical distancing. We're still connected to folks and patients, but we want to exert that and be leading by example. So I'm doing the same with all of us. I keep I'm pretty much hermit in my office nowadays. I only tell them communicate through Skype or any other of these resources online. I want to see their faces too, but I want to make sure that I'm protecting them as well. I've been reviewing the schedules as everyone else and making those advanced plans for most of them, see which patient is telemedicine, which one is not, who can I offer certain things that are different, like the follow-up in the clinical trial or finding a local provider. On my personal end, washing my hands using a face mask in clinic as well. There is some recent reports from the National Academy of Sciences recommending that based on some studies from the University of Nebraska, that there could be transmission even in the absence of cough. So that's why it's so transmissible by just not necessarily respiratory droplets, but just by, exhalation. So I want to make sure that if I'm a potential carrier or not, I want to protect myself and my family. I actually have a change of clothes in my car. So I'm sure there's no cameras because that would be interesting, but I just change everything, leave my shoes in the car. I clean the car completely with gloves and the sanitizing wipes. And then once I get home, I clean everything, leave the shoes outside. take a shower before I actually go and see my family. I mean, I have also a daughter. She's almost a year old now, so I want to make sure that she's safe, and she's been playing here in the house. So yes. So how are you managing work balance and work-life balance with these new considerations like spouses work from home, children homeschooling, or not even homeschooling, but just being here, in shelter-in-place rules, as we had mentioned? So I think, Dr. Gomez, you had mentioned some of that already, but of course, we'd love you to elaborate on that.
Yeah, so what keeps me up at night, right? We just had a medical oncology retreat, and that was one of the questions, right? What keeps us up at night? And they were asking us, so for our program, or, and most of the answers were, either open charts or the puppies that move in the bed. What's keeping me up at night right now is this concern over daycare and safety, right? So the daycare in town is open. The daycare in town is decanted in essence. There's only 12 children because of the change to our standard of living. And they're doing every precaution. All temperatures are taken, both parents and children. Parents are not allowed in. So the safety of the baby, so that I can continue to do my work and provide care for my cancer patients. So then there's two, right? So then he comes home and I come home. And so how do we balance this? How is the safety? Where do we intervene? And what you guys are doing with respect to letting the car be the barrier, right? The place where we change or sterilize. So those are my concerns right now. And as mentioned earlier, with Yale's support of physician wellness, now is the time to practice all the things that we have been trying to grow in our lives, be it spiritual growth, if you wanted a stronger prayer life, or if you were practicing yoga or present moment mindfulness forever. Now is the time when we're being called to truly implement that. What does it mean to embrace the present moment when the future is unsettling? So personally, that's what I'm taking on. Like, now is the time. My yoga teacher says that yoga is for when life off the mat. So now we're asked, where is it safe to breathe, find our center, find our equanimity, almost in the words of Osler, right? But globally, nationally, and then personally at home. So it's the time to incorporate all of our coping and make it real now. How can we then serve our family and our colleagues and our patients as being the best person? So those are the things that's my work-life balance right now. My meditation, and then running to daycare, making sure that is safe, and getting back to work next week again safely.
No, thanks for sharing. I mean, we understand this is all these personal perspectives, which are typically we don't even share with many folks. So we really appreciate that you're sharing your daily coping with this. And I think all of us are going through the same, and it's paramount that we keep that work-life balance if we want to keep serving our patients in the most appropriate way. So thanks for that. So now, Dr. Suarez.
Well, I'm fortunate enough that my husband right now is a stay-home dad. So that's great because we have two kids, a 6 years old and a 10-month-old baby. But I have to say, because my husband is super busy with the baby, we're failing big time with homeschooling for my 6 years old. Even though we got assignments from the school to do with her, we just don't have the band. The reason is because he's busy with the baby, and I'm busy with teleconference when I'm home, or I'm here. I'm trying to at least balance when I'm not in clinic, that I can do things from home, to be more at home doing the video conference that we're doing. But yeah, so because of that, there's a lot of screen time for my 6-year-old. So I don't think I am acing the work-life balance yet, unfortunately. Definitely, I download some apps for meditation to help me to cope with this whole situation better. But not in my best right now in terms of work-life balance.
I think we completely empathize, because now we're not only like there's a lot of things where we assume that was taken care of, such as, the kids at school, and they're taken care of, they're well fed, and then we see them later after we come from work, even though we have the regular help. Now it's extra because we have to manage these patients remotely, and having to also want to have a time with our kids. I think the three of us have young children, so we can all empathize with that 100%. On my perspective, what I'm trying to do, of course, trying to cope, I mean, it's not 100%, is trying to set up a daily routine. So trying to dedicate my personal time to work, and then put a time in my schedule and say, this is the time when I'm going to play with my daughter, like Natalia. So I have like an hour and a half that I'm just dedicated to that, no matter what. So at least I know I'm doing the best I can, given the circumstances, and the rest of the world can wait. Something that this pandemic has shown me is that as much as we love our careers and anything we're doing, we also have to focus on the family and make sure that we have that communication with them. So I'm reaching out also to my family. I mean, as you probably know, I'm from Colombia, so I have all my extended family there. I talk to my grandmother, who I want her to be safe at home. So I'm taking those tiny bits of time to really communicate and reach out to them, and that gives me back a little bit of my balance in life, and gives me the energy so I can keep moving as the next day. In terms of my personal space, have a dedicated area for office work. Interestingly enough, for this webinar, actually in my daughter's room, so it's not my dedicated workspace typically, but it's just part of that as we adapt to those things. And as we're accommodating our patient needs, also preparing myself mentally that we may have to spend less time at home, because we may need to be at the hospital in the forefront. So something that we need to be mindful as well. So that's part of my mind process right now. All right, so next question is, what is one positive thing you're taking away from this crisis? So better person couldn't be than Dr. Gomez.
I don't know, but thank you. Thank you. I really am impressed, in fact, mind blown at that whole concept of we are one. If we've ever believed in it or doubted it, now is the time to come face to face with it, to taste it, to touch it. We are one. This whole physical distance versus social distance, right? So I'm an extrovert, and life is protecting me because there's a baby at home, and so I don't feel at all that my time at home is away from things. But that focus, that connectedness. So my parents are down south. They're immune compromised from other things, rheumatologic conditions, and my contact with them has been even more. The presence, the support, social media. I'm seeing who is anxious and concerned, and reaching out to those people, reaching out to my friends who have immune compromised parents, elderly parents, hospitalized parents. So the interconnectedness of things, and that the physical distance doesn't need to be social distance. And then back to basics. We've come a long way with technology. I'm impressed at people who are doing school from home. I don't know, these meetings, the things that we are able to do, that has taken us away from what we thought was the most normal thing. Going to clinic, seeing our patients, taking care of our patients. We've been trained to do it one way. And I'm impressed at our creativity, at how much we're being stretched, expanded, to think outside the box and provide care, or meet like this and send a message to our colleagues. Look, I hadn't even thought about wearing scrubs. I think I will consider that on Monday. I hadn't even considered that. So how we can all grow and learn from each other. But back to basics, that we can just stretch and provide what is essential.
No, that's key. And I think all of us are getting this sense of community and really helping each other, and realizing that we're all the same. This virus doesn't really care about where we're coming from or what we do. It affects everyone the same way. And one patient affected is one too many. So I think that's 100% on point. And the thing about scrubs, I think, just as a kind of comment, I actually was looking for my scrubs, and I remember when I became a faculty at Penn, I said, I will never gonna wear these scrubs ever again, the ones from fellowship. So I threw them all away, and I gave them to like a cousin who wanted to have PJs. And then I realized that I probably missed them again to wear them at the hospital. So things that we never thought we were going to use, now we're doing. So yeah, a lot is changing, and we may not ever be the same after this pandemic goes away. We're probably going to change a lot of the things we're doing from this. All right, so Dr. Suarez.
So I think what is most touching, and I take as a positive event from all this, is like to understand how much our patients have resilience, and to understand how much love the patients have for us as well, right? I cannot tell you how many messages, phone calls, or emails I got from patients from my current institution, and even from past institutions, to make sure that I'm doing okay, to make sure that I'm being safe, to promise them that I'm being safe. And that just really touches my heart deeply. We're all, I think, very patient centered, and I'm sure you're getting the same love from your patients as well. And it's really also another thing is teaching me that telehealth and telemedicine is very possible, is very effective, and once in a while it might be actually be fun, right? Because you can see the patients in the comfort of their homes, and that's makes your patient become even more personal to you. I feel like all my patients are almost sort of my extended family. To see them at home it really adds a special touch. So that's my silver line on all this.
Right. I mean, it just always brings me back to how physicians used to take care of patients in the past, like not in this modern age, but when you were the physician in the town, you actually went to each home. Remember, they have this in the movies, they have the small thing with the small bag with the stethoscope and all these things, just to check on the patient at their homes. And they left after that. So I think we're doing the same, but virtually. We're less disruptive, and we can do it at the time when it's right. So I think this is something that probably is going to become more mainstream. Hopefully we can continue to do that, because I think it's also a matter of administration, right? So we would love to do that, but we were not really allowed to, because that wasn't really reimbursed. Now we can potentially serve those patients and do that. So let's see what happens. On my end, I think I echo all your comments too, as always. I think I found this spirit of collaboration among all team members in my hospital, with my nurses, with the patients. Everyone's engaged on getting this done, and there's no limit to certain things I need to do. So it's like, okay, we need to start telemedicine tomorrow. Okay, what do you need to do? So that there's really nothing. People work on weekends, getting these guidelines. There was all these limitations that we used to have in the past. They have been pretty much being overcome by this. So that I think that I found this as a great opportunity. We're having more conversations with each other. We're checking our phones less often at home, because we want to be present, and we want to be for those available. And when we're on the phone, we're actually listening. It's not just like gossip or something. We're just actually talking to patients and people, and talking important things for everyone, and checking on their family and friends more often. So I think that sometimes we get so busy in our daily lives that we sometimes lose touch with some folks that are very important to us. And this has given us an opportunity to reach out to them and really have that connection, or renew that connection. I was talking to my college friends, and they're all physicians too, and asking them, hey, how are you guys doing? What are you doing with your families? And kind of, we had a WhatsApp group now. We're just talking about things that we can help each other. So really, really refreshing on that end too. So next question, what is something important for you right now? I mean, there's a lot of, that's a very broad question, but I will let Dr. Gomez to start.
So not only did the world change, but my world changed, right? So the baby came 2 weeks ago, and 2 weeks ago was when this became part of our vocabulary, when this was all that we heard about. So not only did the world change, but my personal world changed. And so personally, my prayer, if you will, is how can I stay healthy to continue to do what we do, what we're called to do, what our vocation has been, and then how do I stay healthy for him now, right? Two, what's important to me right now is the speed of medical research. We are doing coronavirus uh, treatment studies on the go, in vivo, live. Um, the studies are being implemented as we speak. And I was encouraged, Arturo, by your words that we're going to get through this. We're going to do it. We're going to find the vaccine. We're going to find the treatment, which combinations. I'm impressed with the global community on social media, sharing information, sharing research, sharing stories, what works, what doesn't. Of course, the danger of anecdotal data is always there, but we are learning constantly. Each patient, as we've taught our students, is our teacher. And so the speed at which this is changing is keenly important to me so that we can find a way to manipulate this virus, to intervene, to change the course of it. And then again, the communal care for each other. How do we check in on each other? How do we stagger our schedules so that we're taking care of each other so that we can continue to provide the care that's required?
Excellent. I think those are very great points. And I think I'm most impressed of how things are evolving. We're getting these vaccines coming, the use of convalescent plasma from recovered patients, and finding which antibodies may promote more or less inflammatory response, and what drugs can we use to decrease the cytokine release storm that happens within the lungs by the immune system, and really a lot of information coming social media. So I think social media, in particular in Twitter and all that, has really become a major source of information to keep up to speed. And I've seen that like real life. I mean, I'm tracking all these things, and all of a sudden we're just exchanging information and whatnot. So I think this is great. Dr. Suarez.
Yeah, going back to the same theme of trying to minimize patient exposure and sort of keep the theme of flattening the curve, right? I'm hopeful that if we can flatten the curve here in Utah, we're not going to overburden the healthcare system, for one, and number two, we'll have less, hopefully less patients that will be requiring hospitalizations and intubations. So I think going back to everything to me right now is about how can we flatten the curve to go through these here. And obviously, second to that is to protect my family. I have to say that here, in full disclosure, we haven't got to the surge yet, so we're behind compared to the East Coast, particularly to New York. When I talk to my colleagues from New York City, their issues are much different, but that's what is concerning to me right now. So I keep hitting the message. Let's do everything that we can to flatten the curve.
No, exactly. The thing is, we're such a big nation, but also we are so segregated in terms of healthcare access and information sources and different views of stuff. So each state has their own decision making. I think anything that we can share information so people can make really informed policies, I think is key, and we can be part of that because we're healthcare workers. We're in front of that, so this is helpful. On my end, I think I'm echoing the same comments. So I've been talking about flattening the curve from probably like people are exhausted of hearing me say that for a couple months now. Stay at home and save lives, I think, is key for me. I'm telling everyone, making sure that our institutions are ready to face COVID-19 surges, because they will happen at different times, because we're all like in different parts of the US, and the epidemiology follows different patterns. But we don't want to be in a situation where we have to face we told like a scarcity of resources, and we have to make ethical committees and all that stuff. We want to make sure that everyone is taken care of no matter what, and that if the infection happens, then we can actually take care of those patients, right? And then coordination of everyone. So I want to make sure that anyone and everyone we're talking to has the same information and we're all in agreement. We have to work together, because that's the only way we can overcome this and everything starts with you. So if you are a promoter of change, people may follow if you're passionate enough. So that's something that I think all of us are trying to do in our places. So what are a few COVID-19 takeaways that you would like others to know beyond what has been discussed, or maybe to kind of paraphrase, conclude?
So for me, everything seems to have frozen. Everything is paralyzed, but cancer care doesn't stop. These patients are fighting their own disease. They're fighting for their lives. And the premise of cancer care is that we give concerted sequential treatments, and that's how we can manipulate this. So my main thing is, how do we continue that? How do we focus on treating the cancer in this era where everything is in flux? How do we transition to longer regimens? How do we provide care? Just today, we needed to see a rash, and I asked my colleagues to do telemedicine to evaluate a rash of a patient on a clinical trial. So how do we use all that we have to continue to remain committed to that which is in the cancer fight? Both treatments, transitioning to longer treatments, seeing them on telehealth, changing regimens, delaying things, seeing how things unfold in the next weeks to months. And then how do we cover for each other? I really believe strongly in this, and we here at Yale are putting together different coverage schedules so that we can maintain our health, our wellness, and then cover for each other as needed. So these are the main takeaways. And again, we are one. Not only are we seeing this right here in this group, my colleagues that I see and respect in this career across the nation, to be able to come together and provide this, and then globally to extend this, that we're learning from each other. These are my takeaways. This is what I'm learning daily.
Super. Suarez?
Yeah, so again, I think we all learn that telemedicine is really possible and effective, and this has been great. I also thought that perhaps in the beginning of all this, we were very concerned that the patients will be not understandable of the circumstances or will not adapt to an extra level of stress of all this. And I have been so impressed by how the patients are adapting well to this, are being in charge, are educating now that, because they are like obviously in this immunosuppressive situation most of the time, they're like really being in charge of educating their families about ways to prevent exposure and care for themselves. So I mean, what we take and we learn from our patients as well, and that being amazing. On a personal level, it also made me think about my values and what is important between work and in my own personal life, just because I recently had to start medications that will potentially decrease my immune system as well. And I'm just internal. I want to help if needed, and at the same time I need to balance what is important for my health. So that also made me, unfortunately, made me think about my values a lot and what is important for my family.
I think these are all important points always to, once again, have that balance and care about you first so you can care of others, right? So the same happens always. So I think my takeaways are pretty similar, but these are more like scientific, I guess. So cancer patients are, to me, a major risk for complications for COVID-19. So we need to be very, very cautious about how we approach those patients, because we have seen already reports from the Chinese experience and from Italy experience that there could be a twice a risk of complications from COVID-19, including patients who have been survivors. So something that we need to be mindful of. Second, in GI malignancies, we have some options to modify regimen schedules and diagnosis, and to limit clinic visits, so they don't have to see us as often. It's an opportunity for us to kind of recreate ourselves in our practices and helping those patients to get access to treatment without compromising their safety. And lastly, some clinical trials should still move forward. And as Dr. Suarez had mentioned, and also the opportunities at Yale by Dr. Gomez, we need to have just flexibility. So we have to be open about who can we serve under research, if they can continue treatment, because that's also another set of patients that they really need to come to get treated, because that's part of their response to treatment. If they're doing remarkably well on a drug, we don't want to stop it unless it's really necessary. And transfer patients and work with local practices to continue care. Now we have guidance from the FDA and from the NCTN. All of us have NCTN guided trials that are sponsored by the NCI, so we can potentially work with local providers as long as we oversee the care. They can receive a standard of care locally, or we can transfer patients in between as well. So it's a matter of really having an open conversation and be as flexible as possible to help everyone. So I think this wraps up the conversation. There's probably way more things that we can talk, and things are evolving. So we probably will be even thinking further about this COVID-19 and cancer care in our practices. But this is it for now. So I want to thank all the panelists for being so open and willing to spend their time and in their busiest schedules amid this outbreak to share their thoughts and experiences. And we're looking forward to have further conversations. Thanks, everyone.
Thank you. Thank you.